knots have not started appearing, and you have thyroid cartilage here, you have the arachnoid cartilage, so you are at the level of the false cord, and it is just above the ventricle. This is the ventricle, we will discuss that. Just above the ventricle, that is the false cord. So if you have a lesion here in the false cord, it can go anteriorly into, laterally into the paraglottic space, anteriorly into the anterior aspect of the thyroid cartilage. Then you can go posteriorly, and always when you have a lesion here, always you look for thyroarachnoid gap. This is the thyroid cartilage, this is arachnoid, and if you have a tumor which grows posteriorly, always you can have a widening of the thyroarachnoid gap, and then it can gain access posteriorly. So always you look that thyroarachnoid gap is involved or not. And then ventricle, so it is nothing but it is between this area. So if you look here, this area, this is the ventricle. Okay, false cord, then the ventricle, then you have the true vocal cord. Always it is very difficult to make out the ventricle in the axial plane. Always you look in the coronal plane. Then, so this is the epiglottis, you have the false cord, you have the ventricle, and you have the true vocal cord. The coronal views are important for two things. One, to look for, say, if you have the early paraglottic fat infiltration. This is the paraglottic fat. You have a tumor here. The early paraglottic fat infiltration you can make out in a coronal view. And also you can have a subglottic extension. Okay, I will show you in the subsequent slides. At the level of the true vocal cord, so you have the thyroarachnoid muscle there. You have the arachnoid. You have the cricoid. You have the arachnoid. You have the cricoid. You have the thyroid cartilage. And also another structure which is the apex of the piriform sinus. So these are the structures you see at the level of the true vocal cord, along with anterior commissure and the posterior commissure. So this is the, you look for a small slit between the arachnoid cartilage and thyroid cartilage in the posterior aspect. This is the apex of the piriform sinus. So if you see all the big boys, okay, arachnoid cartilage, cricoid cartilage, and thyroid cartilage in the same plane, you say you are at the level of the true vocal cord. Again here, this is a cricoid cartilage. And this area is made by this muscle, this is the thyroarachnoid muscle. And what is the anterior commissure? Anterior commissure is nothing but the meeting point of the two vocal cords. And what is posterior commissure radiologically? Posterior commissure is nothing but the area between the arachnoid. This is the interarachnoid area. So between the arachnoid cartilage, this is the posterior commissure. That's how you make out whether anterior commissure is involved or posterior commissure is involved. So to summarize, those who have joined late, okay, this is the tip of the epiglottis. Then you have the epiglottis here. So this is the median glossoepiglottic fold. It is not part of the larynx. On either side of the median glossoepiglottic, you have the vallecula. You have the pharyngeoepiglottic fold here. You have the epiglottis here. Then array-epiglottic fold here. You have the piriform fossa. Again, it is not part of the larynx. This array-epiglottic fold. Then you are at the level of the arachnoid cartilage. You are at the level of the false cord. You are at the level of the true vocal cord. And below the true vocal cord, actually you should not see any soft tissue inside the cricoid cartilage. If you see any soft tissue inside the cartilage, cricoid cartilage, then you have to think that the patient is having a subglottic extension is present. So this is how you make out. Now we will take few clinical scenarios. I have only 10 minutes left. Okay, the T1 disease. So the head and neck surgeon has a great role, although majority of these patients are treated by radiotherapy. And you are the people who diagnose it. You properly say that where exactly the lesion is, doing a biopsy and facilitate us for radiation. And this patient is having a lesion in the anterior 2/3. Always we should have. That's how I expect my head and neck surgeon to give me details. Where the patient is having what exactly is here, anterior 1/3, anterior 2/3, posterior 1/3. What about the anterior commissure? Any lesion crossing the neckline? What about the posterior commissure? Any supraglottic or subglottic extension and mobility of the vocal cord. Each matters a lot. If the patient is anterior commissure, supraglottic, subglottic, then they are all for radiation. And if the patient is having impaired mobility, that whole patient is also for radiation. Only if a patient is having anterior one that is free and the patient is posterior one that is free, fully mobile cord, then only you will take the option of laser treatment. Okay, you may differ. Okay, fine, in general I'm saying. But otherwise all these patients will undergo radiotherapy. Okay, so you have a lesion here. It is an enhancing lesion. Again, what level? It's we are at the level of the true vocal cord. Because you are seeing arachnoid cartilage, you are having arachnoid here, the thyroid, cricoid. You can see an enhancing lesion there. Can you make out an enhancing lesion there? It is extending anterior commissure lesion. So if I contour this tumor, radiologically, this will be my GTV. Dr. Suman, if I am wrong, please correct me. Okay, Then here in T2 disease, this is a T2, this is two patients, T2, because here you can see no soft tissue here, but you can see soft tissue here, the aspect of it. So it's a T2 disease. So this is unique, this is your GTD. So this, again, always you look for either a lesion is having the cortex of the thyroid cartilage is involved, and it becomes T3 because, and most of the time at the level 2 occult, you don't have a real paraglottic fat, because that stops just above that. So if in that, because most of this is made by the thyroid muscle, just to lateral that, it is the thyroid cartilage. If you see anything, then it becomes T3, because then it becomes, you need to treat with chemo also. Here again, it is having a lesion there, it is coming down, it's a subglottic extension is present. Always you look for that, that's a T2 disease. Any supraglottic, any lesion extending in the subglottis, that is T2, impaired mobility is T2. Then always when you have a T2, by endoscopy, it's my duty to see that it is not T3. Whenever you say hemilarynx fixity, in the endoscopy, my job is to rule out the patient is not having T4 disease. So whenever you have a T1, I have to rule out T2. If you say T2, I have to rule out T3. Okay, radiologically, then I have to plan treatment accordingly. Transglottic carcinoma, everyone knows I'm skipping that because I have time. Pre-epiglottic space, it is bounded superiorly by higher epiglottic ligament, which is, we cannot make out that. That is higher epiglottic ligament is nothing but the fold of mucosa which is covering the median glossoepiglottic fold radiologically. So this is the superior surface. Posteriorly it is the epiglottis, and posteriorly it is attached to the thyroid cartilage. Okay, here you have the anteriorly it is the thyroid membrane. Paraglottic fat. So this is a pre-epiglottic space here. This you can see a lesion, enhancing lesion there, involving the epiglottis and the pre-epiglottic space, and the cartilage is intact. So it's a T3 disease. This is the paraglottic fat. Okay, laterally continuing as paraglottic fat. Here you can see the lesion is involving the. This is a left paraglottic fat is free. Here you can see the right paraglottic fat is involved here, and it is lesion is involving there. It is extending in the epiglottis and the epiglottic fold. Here you can see the paraglottic fat is obliterated. The other thing you have to bear in mind whether you are dealing with an inner cortex involvement. So whenever you see an inner cortex involvement, always ensure that you have a thin slice CT scan. Okay, we use a 0.6 to 5 mm. Then ensure that it is not T4A, because whenever there is a through and through cartilage, then that patient should undergo total laryngectomy. Otherwise, the patient can be taken for chemoradiation. Here you can see always you look in the bony window also. Okay, never see the always you look the thyroid cartilage in bony window, and you can see that there is in this involvement. You can see the inner cortex involvement. Okay, again this is subglottic extension, subglottic extension, subglottic extension. Now here you have a lesion. So at what level it is? This is at the level of the arachnoid cartilage. So it's at the level of the fold score. Here you have a lesion. The right paraglottic fat is free. The left paraglottic fat is obliterated. Here you can see the widening of the thyroid arachnoid gap, and the lesion is gaining access posteriorly here, and the patient is having again here, and this is the lesion is more or less up to here. It's a T3 because of the paraglottic fat infiltration. So T3 means the three things I have given in white and two in this yellow. This you can make out by endoscopy, hemilarynx fixity and post-cricoid. The paraglottic fat, epiglottic space and inner cortex, and all are treated by chemoradiation if there is no aspiration. But you need to understand that this patient is having can be made out only by a CT scan. Another factor we always look when you are dealing with a bulky disease, whether the patient is having airway compromise or not. Whether the patient is in active stridor, definitely you should do an tracheostomy. But if you have a mild stridor and if you have a biopsy, always you have an option of giving induction chemo. And never take these patients for definitive CTRT, because if these patients are taken for CTRT, the patient will have a tracheostomy in between. So this patient will be maybe after 50-10 fraction and one cycle of chemotherapy, the patient will be forced to undergo tracheostomy during treatment. So always you take the patient for induction chemo, and any patient who have a bulky disease after induction chemotherapy, you rule out an aspiration also before taking the patient for CTRT. So that's also important. When coming to T4 disease, this is a heterogeneous disease. The patient with through and through cartilage, everyone agree that this patient should undergo a laryngectomy. But the patient is having tracheal infiltration, that's also T4A. Extensive muscles of tongue superior, that's also T4A. Patient is involving thyroid gland, that's also T4A. And patient is an extralaryngeal spread through a thyroid membrane or a cricothyroid membrane, that's also T4A disease. So this all may be treated with chemoradiation, but always rule out there is no functional loss. Coming to T4A, with this one, you have to think that thyroid membrane, cricothyroid membrane, these are areas where you can have an extralaryngeal spread with cartilage intact. Okay, I have only 2 minutes. Okay, I will try to finish at the earliest. So this you can see always you have extralaryngeal spread. Here you can make out here. This is the thyroid membrane. So always one of the thing the previous speaker has widening of the thyroid cartilage and splaying of the thyroid cartilage. Sometimes you can see a splaying of thyroid cartilage, and this is a sign of advances. Most of the time the young residents may present as lower. It is not lower. It is actually something anterior and it's more hard. Okay, you have to think that you are dealing with a disease which is advanced, T4, clinically itself. Okay, one area to look is thyroid membrane. Other is the cricothyroid membrane. So if you look here, this is the thyroid cartilage, this is the cricoid cartilage, this is subglottic extension. It's the minimal cricothyroid involvement. This is very important as for me, because if I miss this in contouring, definitely this will occur. There will be a geographic miss, and this will the patient have a compromise in meconium control. The patient. So what we are discussing so far is how to diagnose then and also decide treatment. So up to T3, everyone agree that it is a CT-RT if the patient is in good performance status and patient is less than 70 years and good creatinine clearance and no aspiration. That's it. Then you take the patient for CT-RT. But once the patient is having a through and through cartilage destruction, then that's a different. So you have a lesion here. So when you have a T4A disease, what are things you have to bear in mind when you look in a CT scan? One, what about the internal carotid artery? That's number one. Then the patient, second thing is that what about the thyroid gland? Whether you need to address the thyroid gland surgically also. That's also very important. So other thing we have to, when as a surgeon, as the surgeons always you look the extent of the soft tissue in the anterior aspect, because how you are going to reconstruct. And these are all concerns when you look into the CT scans. And so in posteriorly sometimes the lesion is gaining posterior. That's also there in the what about the prevertebral muscle. So what about the prevertebral fascia? What about the carotid artery? What about the thyroid gland? And also the extent of soft tissue involvement anterior. So this is chemoradiation. This is surgery followed by radiation. So all patients who are undergoing a surgery also should have an adjuvant treatment. If it's a pure glottic tumor, majority of the patient may have only N0, T4 N0. Only 20% of the T4 or pure glottic carcinoma patients can have a lymph node. But this patient should undergo an elective neck dissection. The reconstruction is required, and the patient should undergo an adjuvant treatment as well. Yes, I'm finished. 2 minutes. Yeah, only 2 more slides. Coming to T4B disease, it's a highly heterogeneous disease. It can be due to encasement of the carotid artery, it may be due to prevertebral fascia involvement, or it may be due to a mediastinal involvement. So in this is a heterogeneous disease. If a patient is having a cartilage is intact and the prevertebral fascia is there, and then that patient can be taken for chemoradiation. But if the patient is having prevertebral fascia is there and the patient is having a cartilage through and through destruction, then that patient becomes a candidate for induction chemotherapy and reassess the prevertebral fascia, preferably with an MR, and take the patient for surgery followed by an adjuvant program. Yes, now coming to the last part. This imaging, this is a checklist. Always you should look whether it is a primary tumor in the glottis, supraglottis, oleum, size. This can only be made out in CT scan. What about the pre-glottic space, paraglottic space? It becomes T3. Post-cricoid involvement from the supraglottis is T3. Extends to other subsets, it becomes T2. Anterior commission and posterior commission doesn't have staging implications, but there is a chance for transglottic spread. Anterior patient can have T4 disease, and it's also important for radiotherapy planning, whether it is cartilage are intact or inner cortex through and through anything, superior inferior external disease, whatever thyroid gland, cervical esophagus, prevertebral fascia, carotid artery, extralaryngeal spread, lymph nodes. Try to learn by yourself, and now I will take, if I permit 2 minutes, I will. Yeah, thank you. So if you have this, this is the right side, this is the thyroid cartilage, this is a cricoid cartilage. So you have a lesion there. Can you make out an minimal extralaryngeal spread here? It's a T4 disease. So here you can make out there. This extralaryngeal spread. Here this is the paraglottic fat, this is the ventricle on the right side is involved, and you can see a minimal subglottic extension here. Extralaryngeal spread, paraglottic fat infiltration, and but the cartilage is intact. This always you look in thin slice and you always look in all planes and rule out that cartilage is intact or not. And I will give you another example and I will stop. This is at the level of the arytenoid cartilage, enhancing lesion, obliteration of the right paraglottic fat. You are seeing a lesion at the level of the true vocal cord. You cannot make out the right arytenoid cartilage here. Erosion of the inner aspect of the cricoid cartilage. Anterior commission is involved. Subglottic extension is there. Again, and there is an erosion in the thyroid cartilage in the inner aspect. A minimal cricothyroid membrane. This may be an extension, maybe subglottic extension. You can make out that in the subglottic, this area. Okay, and here you can see subglottic extension is there, and you can see soft tissue. No soft tissue here. There is a soft tissue here. So that is a subglottic extension. The inner cortex involvement is there. Paraglottic fat involvement is there, and subglottic extension is present. And the lesion is also a transglottic extension from here to the subglottis. So I'm skipping here. I'm stopping here. Notes I will skip. Okay. Thank you very much for your patience.